And so thrilled to be able to have her here. I think it's a real treat for us all to get updated in this area. So Dr. Idowu, thank you so much for joining.
Thank you for the introduction, Dr. Savitz. I'm going to share my screen. Okay, can you see my screen?
Yes.
Yes.
Okay, so I'm going to be talking about cerebrovascular complications of sickle cell disease and some of the novel sickle cell disease therapies that are coming out soon. These are my disclosures. I'll give you a moment to look through. Our learning objectives for today are to be able to identify various cerebrovascular complications of sickle cell disease, to describe primary and secondary stroke prevention measures in sickle cell disease, understand the role of red blood cell transfusion in the management of stroke, and determine the mechanism of action of at least one novel sickle cell disease modifying therapies. So a little bit of an introduction. Sickle cell disease was first described more than a century ago in 1910, to be specific. One of every 365 African-American births in the US is affected by sickle cell disease. Approximately 100,000 individuals are affected in the United States, but more than 7 million people are affected worldwide. And sickle cell disease disproportionately affects Blacks and Hispanics in the United States. Stroke, silent cerebral infarct, cognitive morbidity are the most common permanent sequelae of sickle cell disease in children and adults with I've already mentioned sickle cell disease. There are currently 3 FDA-approved disease-modifying therapies for sickle cell disease. Sickle cell disease is a single gene disorder in which the glutamic acid at the 6 codon of beta globin chain is replaced by valine, which is more hydrophobic. And this is what's really caused the disorder. And in order for any patient to have sickle cell disease, they must have at least both of their parents must have sickle cell trait or the disease. And this is as depicted on this picture. You can see that the mother has sickle cell trait AS, and that's hemoglobin AS, and father hemoglobin AS. And they had one child. I mean, with each birth, they have a probability of 1 in 4 chance of having a child with sickle cell disease. There are different types of sickle cell disease genotypes that have been described. Hemoglobin SS is the most common and the most severe genotype. And it's also, we also have hemoglobin sickle beta null thalassemia that is as severe as SS. There are other genotypes. The sickle beta plus is also there, but it has moderate severity. And I will mention that a little in my next slide. And then we have hemoglobin SC, SD, and many other genotypes. Now, if both of these hemoglobin, are abnormal and one of them is S, then that is a sickle cell disease. That's how we define sickle cell disease. Both of them are abnormal and one of them is S. And as you can see here, this is a table that shows the clinical and lab findings in sickle cell hemoglobinopathies. And with SS, I did not put sickle beta null here, but SS and sickle beta null, they have marked severity, so quite severe clinically. And the baseline hemoglobin for these patients are usually 6 to 8 grams per deciliter. If we do hemoglobin electrophoresis and they're not transfused yet, hemoglobin S will be more than 90%. So basically all of the hemoglobin, except for the A2, would be S, is what I'm saying. Some of the patient can have a tiny bit of fetal hemoglobin left. And of course, if they're taking hydroxyurea, this can be more than 10. And sickle beta plus have mild to moderate severity, just as hemoglobin SC disease. And you can see that the baseline hemoglobin look better, 9 to 12 and 10 to 12. And these ones, the sickle beta plus and SC, these are the ones that have, close to normal hemolytic labs. And sometimes when they come into the ED, they're not, people do not even believe they have sickle cell, they have normal hemoglobin until they check the hemoglobin electrophoresis or they look at their records as outpatients and see that they have sickle cell disease. But you can see here, when we do hemoglobin electrophoresis on these patients, the sickle beta plus will have normal A. Hemoglobin A will be present without transfusion. So that is how to distinguish between sickle beta null and sickle beta plus. Sickle beta null doesn't have any A present without transfusion, but sickle beta plus would have 10 to 30% hemoglobin A. So the vaso-occlusion in sickle cell disease is initiated by the presence of the sickle mutation and high concentration of hemoglobin S within the sickle erythrocytes. And of course, it's a mixture of issues. The neutrophils secrete a lot of injurious cytokines. And then you have the coagulation factors are present. Sometimes the platelets will secrete all the, substances that make the coagulation even more. And then sickled erythrocytes are even, of course, causing more injuries. And these are constantly going on. And the selectins are being released, integrins and everything else from the endothelium. So a lot of things are going on, a lot of inflammation ongoing, and the vasculature is really impaired. Most of these patients have multi-organ dysfunction as a result of the vasculature that is not well. And in terms of the phenotypes, there are two overlapping phenotypes that have been described. Some patients have mostly the hemolytic anemic phenotype, which means most of the time they have severely low, hemoglobin. And this is because they typically they have release of free hemoglobin, which scavenges nitric oxide. The superoxide also gets rid of more nitric oxide. The arginine gets catabolized by arginase, which inactivates nitric oxide. So there's less nitric oxide that is available, which causes more injury to the vasculature. And the high hemolysis at steady state cause, of course, chronic severe anemia at steady state. These patients are at high risk for certain complications, such as pulmonary hypertension. Stroke is what I want to highlight here, sudden death, leg ulceration, paraplegia. And these patients are the ones that sometimes they don't come into the hospital often for pain episodes. So they can fool the providers or physician into believing that they're not as sick as the other ones that come in often with vaso-occlusive episodes. So we have, again, the hemolytic anemic phenotype that have the low steady state nitric oxide availability, causing vasculopathy, leading to endothelial dysfunction and chronic multi-organ dysfunction. And then we have the vaso-occlusive phenotype. And that one, this phenotype tends to have higher hemoglobin at steady state, less hemolysis at steady state, more platelets. And their complications are from obstruction of capillaries, and they're the ones that come in frequently with acute pain episode, acute chest syndrome, avascular necrosis, and of course, they're also at high risk for morbidity and mortality. And I'm mentioning this because the choice of sickle cell disease modifying therapies they're based on phenotypic expression and sickle cell disease complications. And there are multiple biological targets in sickle cell pathophysiology, as you can see on this diagram. At the DNA level, we can target the stem cell. We can do stem cell transplants, and I will talk a little bit about that. We can do gene therapy. The treatments highlighted in blue here are FDA approved. We have 2 gene therapies that have been approved. Casgevy is one of them, and Lyfgenia, and I will expand on this in my next slides. And then we have, we can also target the protein by inducing fetal hemoglobin, hydroxyurea, that's the mechanism of action of hydroxyurea, and also hydroxyurea have other mechanism of action. We have other therapies that are currently in clinical trial, like Posureda and decitabine THU. And then we can target at the cellular level by improving the O2 affinity. We have the pyruvate kinase activators. We have hemoglobin S polymerization inhibitor. That's what the voxelotor is. And these medicines actually help improve the oxygenation of the hemoglobin, and they're not sickling as much anymore, and there's less hemolysis. There's certain ones that improve the red blood cell L, like antioxidants. L-glutamine work like that, and arginine. And some anti-inflammatory have been tried, vasodilator. Some target the vasculator, like the selectin inhibitors. P-selectin inhibitor that had been approved in 2019 is crizolizumab. And this is a therapy that is quite useful for people that are having frequent vaso-occlusive episodes, acute chest syndrome, or those that have priapism. And vascular plasma can be targeted. And of course, we know about the use of transfusion and exchange transfusion to treat patients. There are different clinical complications, and this can be divided into acute and chronic complications. The acute ones are the ones highlighted in yellow, and we have meningitis and stroke. And then, of course, sickle hepatopathy, stones, sepsis, priapism, osteomyelitis, splenic infection, sequestration, acute chest syndrome, retinal infection, and then the chronic complications, neurocognitive dysfunction. That's really very common in sickle cell, even when we do not see any, impact or history of stroke or other events. There's still this sort of neurocognitive impairment in individuals with sickle cell that we really recognize. And we have, other chronic issues like cardiomegaly, diastolic heart failure, pulmonary hypertension, and of course, chronic anemia, avascular necrosis, skin ulcers, chronic pain, kidney disease listed here.
Hello. Hey, what's up?
So the FDA-approved therapies, the first approved therapy is hydroxyurea, which was approved in 1998. This should be offered to all adults and children with the severe genotype, SS and sickle beta null, that not thalassemia, that at least 6 to 9 months of age and older. And now we've started to also offer to the hemoglobin SC patients who have severe disease. And L-glutamine was approved in 2017, and we used a pharmaceutical grade called Endari, and it's offered to people that have pain, episodes, increase of hospitalizations. It does not change the lab parameter, transfusion requirements, hemolysis lab, anything, but it does help certain patients' population. About maybe a third of the patients will usually report that Endari or L-glutamine helped them. And then crizolizumab approved in 2019 on the basis of a phase 2 trial, and it's approved for 16 and older for vaso-occlusive crisis, and basically it's to prevent or decrease the frequency of vaso-occlusive episodes and those that are having frequent hospitalization. This therapy does not change laboratory parameter, but it does help certain patients' population in terms of their pain episodes, priapism, and other things. And it's an infusion medicine. We give it once a month. It goes over 30 minutes, and they have to come in, every month basically for it. And then voxelotor, I highlighted this because it was approved in 2019, and then later the drug company Pfizer voluntarily withdrew the approval in September of 2024. And now Pfizer is having ongoing discussion with the FDA about getting it back to the market. And it's a hemoglobin S polymerization inhibitor that help bind, improve oxygenation of the hemoglobin S. Now I'm going to talk about the different gene therapies that were approved. 2 gene therapies approved in 2023. Lovo-cel is the first one. So Lovo-cel is a gene therapy, and what gene therapy basically is when hematopoietic stem and progenitor stem cells, when they're transfused or transduced with the BB305 lentiviral vector encoding the modified beta globin gene. So, and then the modified hemoglobin rather, has a similar oxygen binding affinity to the wild type hemoglobin A, and it prevents sickling. So basically lentiviral and inactivated HIV virus is what is used in this. And the diagrams here show that it's a gene addition technique that is used with the Lovo-cel. So modified hemoglobin gene delivered into the stem cell through a vector, and the vector is the inactivated HIV virus. The cell expresses the working modified hemoglobin gene. There's more production of functioning modified hemoglobin, and then the red blood cells become functioning, is how it's done. And then the pivotal study, clinical trial was published in New England Journal of Medicine in 2022. And basically, as of 2024, they had 55 patients that had received Lovo-cel, but of the 34 evaluable participants, they found out that 88% of them achieved a vaso-occlusive event complete CR, complete remission rather. And 94% of them, about 6 to 18 months post-infusion of the cells, of their own stem cells, they are free of severe vaso-occlusive events, basically. And then of 46 evaluable participants, 89% achieved gene replacement, and 49% that modified. So 49% peripheral blood had modified hemoglobin at 6 months, so which is very good. So this was approved for age 12 and older, and patients that have history of stroke and they're not able, or they don't have any donor available for stem cell transplants, will qualify for gene therapy if they don't have a major issue with their organ that will make them not be able to get the treatment. And the patient that are going through gene therapy, they get their own cells infused back to them. So meaning, basically the process is that they will get their own stem cells harvested from them, and then the cells get sent out to the company that would then treat the cells, return the cells back. They get chemotherapy before the cells will be infused back to them. And then the next gene therapy approved is called exa-cel, and this is a CRISPR-Cas9 gene editing technology that disrupts BCL11A erythroid enhancer on chromosome 2, leading to increased expression of fetal hemoglobin. So BCL11A is a key regulator of the switch from fetal to adult hemoglobin. And if that switch can basically repressed, the fetal hemoglobin can continue to go on to be produced. And that is what's being illustrated down here, the CRISPR-Cas9 technology. The pivotal study that got this approved was also published in New England Journal of Medicine. So 30 patients with sufficient duration of follow-up, and then about 97% of them had freedom from severe vaso-occlusive crisis, 12 months, for more than 12 months consecutively. And then about 100% of them, all of them had freedom from VOC-related hospitalization for 12 months or more. And then their total hemoglobin improved to 12.9 at 6 months. So basically, the hemoglobin got much better. And later on, we'll find out a risk factor for strokes is hemolysis, and we mentioned that earlier. And
they are too light
also,
and not good.
And also anemia. Anemia.
Excuse me,
Anemia
I
is
would like everybody to mute their microphones because we keep hearing on the background somebody's conversations. Please, guys, thank you.
Yeah, anemia is a risk factor for stroke in sickle cell, and also high hemolysis at steady state. So if we're able to repress that and increase the hemoglobin, we believe that this will help people with history of stroke, that they shouldn't have recurrent stroke if you're able to do a transformative therapy such as gene therapy, because we're not calling gene therapy curative therapy yet. We call it transformative therapy. And then allogeneic hematopoietic stem cell transplant is considered the only curative treatment for sickle cell disease. And basically, the cells would have to be collected, stem cells collected from the donor that can be either HLA identical donor or not. It's better to be HLA identical donor or from a cord blood. However, sometimes many of the patients, less than 20% of patients have this donor basically. So about more than 80% do not have HLA identical donor, in which case, now there are multiple ongoing clinical trials in adults studying haploidentical hematopoietic stem cell transplants. And if it's haploidentical, then 50% of the individuals with sickle cell should have a donor. And a systematic review, meta-analysis, put from 1986 to 2017, having close to 3,000 patients, showed the overall survival of people that have had stem cell transplant, allogeneic stem cell transplants, 96% overall survival, disease-free survival of 90%, but the acute graft versus host rate was 20%, and chronic graft versus host rate 10%. Now, in my own experience, some patients, they're not willing to take a 4% chance of mortality from curative treatment, but some patients, they're willing to take this type of opportunity for cure. So it depends on each patient, and it's case by case when we present this idea to patients. Now, American Society of Hematology, which is that is our largest hematology group, their recommendation about HLA match allogeneic hematopoietic stem cell transplant is that the suggested indication is that we should consider related donor transplants in patients who have experienced an overt stroke or have an abnormal TCD, transcranial Doppler. So for patients with stroke, if they have abnormal transcranial Doppler, should consider stem cell transplant. Patients with frequent pain episodes requiring medical attention, consider transplant. Patients with recurrent episodes of acute chest syndrome, consider stem cell transplant. If no matched sibling donor, use alternative donors in the context of a clinical trial. So meaning that the risk from unrelated donor still remain high. So we should use that just in the context of clinical trial. And there's some other information here, such as use transplantation at earlier age, because the people that are still younger, they have less multi-organ disease and dysfunction or failure. So they're at, lower risk when they go through stem cell transplant, because they need, when they do this stem cell transplant, they need chemotherapy, radiation. They're able to take this therapy better with less complications. And then use HLA identical sibling cord blood when available over bone marrow. So now I'm going to switch a little bit to cerebrovascular complications of sickle cell disease. There's quite a few complications of, from cerebrovascular standpoint. So there's what we call silent cerebral infarct, which is not too silent because some of the patients have cognitive dysfunction and they have these subtle other issues ongoing, but there's no focal model or other other evidence of stroke on exam. And then ischemic stroke, maybe it's just an obvious overt ischemic stroke. And then hemorrhagic stroke, cognitive dysfunction can be there with or without stroke. And then headache, microstructural white matter injury, aneurysm, dilation of vertebral basilar system, fat emboli, stenosis of the vessels, moya is quite common, and cortical thinning, volumetric changes. So this is just a picture of all the things, or some of the things, not everything, that can go wrong. The incidence of cerebrovascular disease in, in sickle cell patients. So stroke and other complications represent significant sources of morbidity and mortality in this patient population. And in the longitudinal cooperative study of sickle cell disease, the estimated prevalence of stroke was about 11% by age 19 years and 24% by age 45 years. And the highest risk and lowest age at first stroke happened among people with SS and sickle beta null, because that's the most severe genotype, and also the ones that have the lowest baseline hemoglobin and higher hemolysis at steady state. And then silent cerebral infarct is the leading cause of permanent neurologic damage in SS and sickle beta thalassemia. 39% of children are affected and 50% of adults. And then stroke risk is lower among people with hemoglobin SC and sickle beta plus thalassemia and other compound heterozygous forms of sickle cell disease. Stroke risk appears related to the degree of anemia and hemolysis. I've been mentioning that. And ischemic insults are the most common, accounting for up to 75% of sickle cell disease-related strokes, 25% for hemorrhagic strokes, and then patients at considerable risk of both overt ischemic and hemorrhagic. And the former, which means the ischemic, reported more frequently in children, and the hemorrhagic stroke is more common in young adults. And in a recent cohort study, 10% of sickle cell disease patients' deaths were attributable to overt stroke. And overt ischemic stroke is rarely fatal. However, death may occur following 26% of hemorrhagic stroke. So even though we say could be, people with ischemic stroke, maybe a little less fatality, they're still at risk. But hemorrhagic stroke, they have higher risk of dying. And overt stroke is associated with significant long-term morbidity, including seizures, physical disability, and cognitive impairment. So, and the pathophysiology can be due to different things, a lot of things, because even the pathophysiology of sickle cell is so complex, and part of it, widespread vasculopathy, vaso-occlusion, tissue hypoxia, ischemia, reperfusion injury, chronic hemolysis, nitric oxide depletion, contribute to this chronic inflammatory state and endothelial activation. And then hypercoagulability, complex interaction between the coagulation system and endothelium. von Willebrand factor release, low, and I've mentioned low nitric oxide, upregulation of vascular adhesion molecules like P-selectin, and alteration in the activity of intrinsic anticoagulants like protein C, protein S, and then chronic vasculitis and hypercoagulability in the carotid, vertebral, and cerebral arteries lead to acute infarctive and ischemic stroke, as well as chronic complications like carotid stenosis and Moyamoya syndrome. So it's a lot of things going on that could have caused all the cerebrovascular complications. And to talk a little bit about silent cerebral stroke is an abnormality on MRI that does not correlate with the permanent focal or neurologic deficit. And then the risk factors are low hemoglobin levels, elevated systolic blood pressure, signs of cerebrovascular disease on both intracranial and extracranial MRA. And if patient manifests clinically, it manifests clinically as neurocognitive decline, difficulty with schoolwork performance, and other neuropsych problems. Kind of subtle for some patients, but sometimes it can be more significant. Like if a student was getting all A's before, and all of a sudden they're failing their exams. But in adults, sometimes it's just so subtle that they're just very forgetful of things. And then it's a significant risk factor for overt stroke. So once a patient has silent cerebral stroke, they're at risk for overt stroke. We need to start managing them with secondary prevention of stroke with transfusion and other therapies. So recent reports suggest that people with silent stroke and in SC disease may be more common than previously recognized. So even though we think that SC people, hemoglobin SC individuals are not as much at risk of silent cerebral infarct, we now know that they're also affected. And ischemic stroke and TIA, most prevalent, as we mentioned earlier, 75% of the cases, and then recurrence rate of up to 70% with the highest risk within 36 months of initial stroke if we do not start treating, like doing secondary prevention. And typically we will start transfusing patients, whether simple transfusion or exchange transfusion or using other therapies. And major risk factor for ischemic stroke, prior TIA, low hemoglobin, high white blood cells, and hypertension are the main risk factors. Research indicates that individuals with a history of TIA in sickle cell disease face 10-fold higher risk of subsequent ischemic stroke compared to those without such a history. And long-term transfusion programs following TIA have notably reduced stroke incidence. So anybody with TIA should be treated, should be started on long-term transfusion protocol. For hemorrhagic stroke, I would just quickly mention it's less common than ischemic stroke. It occurs about 25% of the cases of stroke, and but has higher mortality rate. And the prevalence of hemorrhagic stroke in sickle cell varies widely, depending on the study. Intracerebral hemorrhage in sickle cell disease occurs most frequently between ages 20 to 29, so young adults. And then hypertension is a significant risk factor, which is present in more than 50% of these patients. And other risk factors are low hemoglobin, low retic counts, prior, if they've had previous intracranial hemorrhage, or if they are, smokers. And the pathophysiology of this is not well understood. The main suggested mechanisms are vessel wall damage due to chronic anemia, sickling, increased vessel fragility from collagen depletion, smooth muscle hypertrophy, and aneurysm formation. Neuroimaging studies often locate hemorrhages at the cortical medullary junction and in the lenticulostriate arteries territories, suggesting that fragile collateral vessels may be the origin, especially in those patients with Moyamoya. So those patients with Moyamoya with aneurysm, cerebral aneurysm of other causes, they are at more risk for intracranial hemorrhage. So I will talk about primary prevention, and the term, when we say primary prevention, these are interventions to reduce the risk of the first stroke. And secondary prevention, they're intervention to reduce the risk of recurrent stroke in individuals who have already had a first stroke or they've already had a silent cerebral infarct. Transcranial Doppler is a non-invasive ultrasound-based method of measuring the flow rate of blood in the terminal internal carotid and proximal middle cerebral and intracranial arteries. So I will just quickly go through this case, a case of screening and primary stroke prevention in a high-income country. 4-year-old child with SS living in the United States present to the clinic for an annual visit, discussing plans for his visit surveillance. We noticed that the child has recently had 2 abnormal TCD measurements. What is the next best step? So typically we'll start transfusion and to reduce the sickle hemoglobin level. So it can be simple transfusion and it could be apheresis or exchange transfusion. So the annual TCD screening should be performed for children with SS and sickle beta null, those with severe genotype, ages 2 to 16. It's a strong recommendation. For children with sickle cell anemia or children who have compound heterozygous, who have evidence of hemolysis in the same range as SS, who have high hemolysis, who also have abnormal TCD velocities. Blood transfusion should be every 3 to 4 weeks if we're doing simple transfusion. And if we're doing exchange transfusion, we do want to reduce the hemoglobin S below 20%. But the blood transfusion, when we do it, even if we do simple transfusion, after about a year, we notice that the S is suppressed. The hemoglobin S gets suppressed to below 30%, which is great. Because before the transfusion gets started, the hemoglobin S is about 90%. And now it is, it gets lower and lower, and it gets below 30%. And that's where we want it to be. Hemoglobin levels should be around 9 also. So 9, 10 is usually our goal, but we don't want to go beyond 10.5 or 10 and 11 due to hyperviscosity, unless they have exchange transfusion and they have very good blood quality. So, and this graph basically just showed that TCD with regular blood transfusion results in a reduction in stroke. So if they don't get any transfusion, if they continue the transfusion, it's really reduced their stroke. But if they're not getting transfusion, then the probability of remaining event-free is reduced. So the patient has now been on transfusion for 18 months. The family is discussing options for possibly discontinued transfusion therapy. Which of the following answers describe the best next course of action? Patient can be started on maximum tolerated dose of hydroxyurea if he has a normal MRI, MRA. And that is actually from a study. So we call that switch clinical trial, switch study, meaning after 1 year to 18 months, anything more than 1 year, if they now converted to normal TCD, it is okay to actually switch them to hydroxyurea. If they have normal MRI, no silent infarct, it is appropriate to switch the patient to hydroxyurea therapy. And I'm making this point because on the newer therapies, it will probably make sense that when these therapies come around, that they will be effective, close to even probably better than hydroxyurea, or at least as effective as hydroxyurea, or in combination with hydroxyurea is how we're using the newer therapies. So hydroxyurea can replace blood transfusion in select cases in children with abnormal TCD, transfused for at least a year. And the criteria for being able to stop the monthly regular transfusion, if the red blood cell is done for at least 1 year, no MRA vasculopathy, no silent cerebral infarct. It's okay to switch to hydroxyurea. Same is what is shown with multiple trials done here. Okay, so sickle cell disease patient with neurological deficit should have prompt blood transfusion. And prompt blood transfusion should be given upon recognition of symptoms without delay beyond 2 hours of acute neurologic symptom presentation. The type of transfusion, simple, modified exchange, or red blood cell exchange transfusion, full exchange, is dependent on individual patient factors and local transfusion resources. That's a strong recommendation. And optimal timing of intervention with blood transfusion therapy and brain imaging modality has not been rigorously studied. And then exchange transfusion is preferred over simple transfusion. And this is a consensus statement from American Society of Hematology, and it's from the guideline. And then management of acute neurologic events, optimal timing of therapy is to have prompt transfusion within 2 hours in children and adults, an assessment for anemia and percentage of sickle hemoglobin with consideration of transfusion on a case-to-case basis. For individual with hemoglobin levels greater than 8.5 presenting with focal neurodeficit or TIA, exchange therapy to reduce the possibility of hyperviscosity syndrome is suggested, and you will have good enough hemoglobin if you're able to exchange them quickly. And the threshold for post-pheresis, if they go through a full red blood cell exchange, and we call that post-apheresis, hemoglobin S percentage and hemoglobin level are typically set at 15 to 20%, and 10 gram is the goal of hemoglobin. When the S level is 20%, the total hemoglobin level can be generally 10, and even to 12, because when you switch the hemoglobin to good hemoglobin, it's hemoglobin A that they now have. They don't have S hemoglobin as much anymore. So the quality of blood is so good that even if you go past the 10.5, 11, they shouldn't have hyperviscosity with exchange transfusion. But when hemoglobin is so low, when a patient comes in with stroke, if they're at 5, you do want to increase them to around 10. 10 will be a good level to be able to perfuse the brain, and they will be able to have good quality hemoglobin too. In terms of administration of TPA, it should never delay prompt blood transfusion. For adults with sickle cell disease presenting with symptoms of acute ischemic stroke and being considered for IBTPA, within 4.5 hours of onset of signs and symptoms and without contraindication for thrombolysis, the panel suggests management using a shared decision approach. So for all patients, the administration of TPA should not delay prompt, simple, or exchange blood transfusion therapy. And patient may be evaluated for IBTPA based on its established inclusion and exclusion criteria. So now I will talk just very briefly about the newer therapies that have come out, that should hopefully be coming out soon. Some are in phase 3, and they are very promising. So this is just a table that kind of outline how we treat sickle cell in general, SS, sickle beta null, severe genotype. Hydroxyurea is kind of offered to every individual. And then severe anemia, if they have red blood cell immunization, they're not able to get a lot of transfusion. I will offer pyruvate kinase activator, which is a group of medicines that are coming out hopefully soon, but they're in clinical trial right now, phase 3, about 2 to 3 of them. And they are very promising because they will increase hemoglobin by decreasing hemolysis rates significantly. And this can also be useful for people with stroke, hopefully, because as you can see, the risk factor for having stroke is when they have low hemoglobin at steady state because of high hemolysis and because of they have low nitric oxide bioavailability at steady state. So the drug, the way it works, majority of them is by helping to deal with the issues. So this is a 20-year-old with high hemolysis at steady state, indirect bilirubin 5.5, LDH 450, and hemoglobin about 6, was interested in newer therapy, just anything that can help them. So we kind of introduced the clinical trials to them. pyruvate kinase activator or hemoglobin S, polymerization inhibitor, osivelotor, GBT601. So imagine investigational pharmacological therapies, direct hemoglobin S polymerization inhibitor. Osivelotor is one that is quite promising, and I will talk about it again. Pyruvate kinase activator, we have 3 of them in clinical trial. Mitapivat is in a Rise Up study, it's phase 3 now. Etavopivat is also phase 3. Hibiscus study, and then AG946 is phase 2. And then those that are fetal hemoglobin inducer, decitabine THU, it's also called NDEC, and it's going to phase 2, and Posureda is phase 1. And then we have others that would decrease cell adhesion. P-selectin inhibitor, the only one that is approved is crizanlizumab, and it's FDA approved. And osivelotor is a next generation Sickle hemoglobin S polymerization inhibitor. It's basically, it's a small molecule that stabilizes hemoglobin in the oxygenated state. And by doing so, there's much less hemolysis. And when we look at the cells under the microscope, they actually look like normal, nice, spherical red blood cells. And hemoglobin for patients, I will show you, you can see in the 100 milligram group, the mean increase in hemoglobin was actually about 2.8. And in a 150 milligram group, 3.6 was the mean hemoglobin increase. And within 2 weeks of starting, we usually will see the increase in hemoglobin, even within 1 week, as you can see on the left of this slide. So, and the other things we noticed was that there wasn't any indication that there was poor oxygenation to tissue, so no hyperviscosity issue, because EPO level was not, going up. So ectocytometry also suggested red blood cell deformability was improved, and there was delayed S polymerization. So it was really promising. The other things that we hear from patients is that they have better energy when they take this medication, and they feel very close to normal people when they take the medication. And I have patients that they have baseline of hemoglobin 6, and the hemoglobin will go nicely to 10 or 11, and they feel very well. And then pyruvate kinase activators are the other ones. Pyruvate kinase is a key enzyme in red blood cell metabolism, and the production of, and it's very important in the production of ATP. Sufficient ATP is needed to maintain red blood cell energy homeostasis, membrane integrity, and deformability. And the decrease in PK function leads to defect in glycolysis and the buildup of 2,3-DPG and reduced ATP. And so 2,3-DPG is an important regulator of oxygen affinity in hemoglobin. And red blood cell sickle cell disease, PK activity and stability are reduced compared to the healthy control. So these are the 3 agents that are in clinical trial right now that are pyruvate kinase activator. Mitapivat is phase 3, like I mentioned. Etavopivat is also phase 3, and AG946 has gone to phase 2. And they're all also promising medications. They decrease hemolysis and increase hemoglobin level. Patients feel better, they feel energized. In fact, the ATP, of course, it's kind of the energy of the cell, but it seems like it's because of the hemoglobin going up, the oxygenation is better. Patients feel the energy also. So overall, this diagram just depicts what we talked about. And this is a study of mitapivat, and it's what we published. Initially, I presented this at American Society of Hematology meeting, and then after that, we published this in Lancet Hematology in 2025, the results. And this was our phase 2 global study. And this was the ASH publication, and this was the Lancet Hematology publication. So, and I will not go through every one of these just for the sake of time. Etavopivat, similar medication, pyruvate kinase activator. This was also published in Blood Advances. and we're part of the team that did a phase 1. And now, I mean, we've gone to phase 2 and now phase 3 of the study. Pioneer study, Posiredra. This one is a fetal hemoglobin inducer. It's still in phase 1. We're waiting for preliminary data. We'll present that at ASH 2025 in December. So back to the case of the lady, she started one of the medicines. Her hemoglobin went from 6 to 9 to 10. Bilirubin went from 5 to about 1.6. So it's almost normalized. And LDH went from 450 to 250. She was able to continue her college uninterrupted, and she had very good quality of life. I will end with this. We're part of this ASH, American Society of Hematology Research Collaborative Network, and it's kind of a clinical trial network. And it uses the power of its multi-center. It's kind of a nationwide network. And it uses that power and having all the experts to address key clinical questions and gaps in sickle cell disease care. And it periodically issues requests for application to members in its research network and provides seed funding to stimulate the development of ideas that translate into extramural funding application. And we're part of actually the council sites, like if you see on the right, the funded site, and there are 20 of them, 20 sites that represent the network council that acts as the steering committee. And they care about industry-sponsored clinical trial, investigator-initiated. The one we start from here, they can help us fund that, and then real-world data, patient community engagement. So we have multiple clinical trials ongoing at once. This is not the whole list, but we have quite a few of the medication clinical trials ongoing, and those that also non-medication are not listed here. Algorithm for treatment of stroke exists. I will not go through this, but if a patient with sickle cell have stroke, what to do with them within certain number of hours, thrombolysis, or not. They, of course, if they're within the hours, that you can consider that as long as they don't have anything that is ready to bleed, and other recommendations that we've already talked about. I would like to mention that in adults, we should do at least one MRI as an adult to look for silent cerebral impact. This is number 3 here. At least once in early school age children and once in adults with sickle cell SS and sickle beta null. This is a recommendation. And because we know 50% of them have silent stroke, they just probably don't know about it. So in conclusion, I want to conclude that sickle cell disease is a single gene disorder with a complex phenotypic expression. Stroke and other complications of cerebrovascular disease represent significant sources of morbidity and mortality for people with sickle cell disease. There are specific guidelines for primary and secondary stroke prevention in sickle cell disease. Stroke risk appears related to the degree of anemia and hemolysis. There are multiple potential biological targets in the pathophysiology of sickle cell disease for development of therapeutic agents for complications such as stroke. Novel sickle cell disease modifying therapies are under clinical investigation with some encouraging results. And I really thank you for your attention. Sorry, I went to the end. I will take questions now.
I do have a question.
Yes.
Yeah, thank you,
Let me stop sharing.
Thank you. It was a very informative lecture. I'm currently a vascular neurology fellow, and I used to do TCD before for sickle cell patient. So my question here, we know from the STOP trials that in TCD, if you find that the mean flow velocity is above 170, it's considered conditional, and you repeat the scan in 6 months. If it is above 200, then we have to do exchange transfusion or apheresis. But my question, beyond the age of 16, is there any current trials that you're aware of, whether like TD helps or just an MRI, like you said?
Your question, to repeat, is that are there certain studies looking at, for example, MRI findings in adults? apart from, or just TCD screening in patients that are older than 16.
Yes. So does TCD rule apply for above 16 or not?
So right now, the recommendation is 2 to 16. That's the recommendation, the national recommendation, that we don't have to do it beyond then. And part of the reason is that it's probably difficult to capture, although I see that now neurologists sometimes they do it for adults. So maybe our neurology expert can tell us, can you see clearly? What can you gather when you do it for adults? The recommendation from hematology, sickle cell standpoint, is 2 to 16. Above that will be more of imaging, like MRI and everything else.
Okay, thank you.
Yeah.
Thank you, Dr. Idowu. Thank you so much for the wonderful presentation. I have a question for you. How can we reach your office? Only because it's kind of hard to get patients in. I do have plenty of patients that we're seeing our Texas children as, children, and now they're adults, and they will just send them to my clinic. And when I look at their medications, giving your presentations today, I don't think they are all taking the right medications. So is there a way we can refer them in a timely manner where they
Yes.
can be seen? Okay, please, I would love to have that information. Thank you.
Yeah, and you can email me, or I can type my email in the chat. But if you also type UT Comprehensive Adult Sickle Cell Center, you can reach us through that. You can refer through that. However, if you email me, we can expedite things, and I can connect you with the community health liaison, because that person can get new patients in quicker. And that's our job, to link people that are not linked to the Sickle Cell Center, to help them get appointments earlier.
All right, thank you.
Yeah. And I believe our website now should have actually her name there. We just need to make sure that we actually put community health liaison for new patients. Yeah. All right. Any other question?
I had a question. So the pyruvate kinase really is, the activators sound really interesting. And then that case example you gave where the patient couldn't tolerate hydroxyurea, and you put them on, the hemoglobin went up afterwards. And I was thinking about that, like how that would work, because I was thinking you were mentioning it's more about the energetics. How would hemoglobin increase by those pyruvate kinase activators? Just curious.
Yes. So basically, the way they work, they decrease hemolysis. So it does decrease hemolysis significantly, in fact. And by doing that, hemoglobin will go up.
Yeah.
So, and the people that I actually select the clinical trials for, I suggest that they need the clinical trial. They're the ones that have steady states, increased hemolysis at steady state. Hyperhemolysis at steady state is what I call it. So some patients, when I see them, they're fine. They don't come in often with vaso-occlusive pain episodes. But what I see when they come in is that they come in with bilirubin of 5 and 7 and 9. And I know that they're in trouble. They're the ones at risk for pulmonary hypertension, sudden death, stroke, and they're the ones that will have that multi-organ failure earlier than later. They're the ones that are fooling the providers to thinking that they're doing just fine, because they're not coming in frequently with pain, but they have active hemolysis, and they're the ones with severe anemia at steady state. So, but if we can put them on any therapy that would decrease that hemolysis at steady state, it will then improve and I think it's by lowering the 2,3-DPG, because that helps with sickling. When you decrease 2,3-DPG, then the sickling will definitely improve. Yeah.
Are you seeing any side effects from them? From
So
those,
the interesting
pyruvate
thing
kinase?
is that we don't see much at all. In fact, some of the patients, they're asking me that are they supposed to feel anything? But the only side effect I would say for a couple of the patients would be mild headache, if anything, mild, very mild headache. Yeah.
Yeah, that's okay. And they're
Yeah,
still under investigation, you said. So they're not yet part of the clinical protocol pathways.
not yet. They're not approved yet. But the way they're going for sickle cell therapies, once they get to phase 3, then the company work on kind of expedited approval because it's considered an orphan drug. And that's why crizanlizumab was actually approved through a phase 2 data. That was the p-selectin inhibitor. It was approved on the basis of a phase 2 data. And it was because we just didn't have anything at that point. We only had 2 drugs at the point that crizanlizumab came along. And now there are still 3 FDA-approved therapies. And we don't have any therapy currently that would decrease hemolysis and increase hemoglobin. As much, of course, we have hydroxyurea. Hydroxyurea does everything, but at the same time, I still have this patient maximized on hydroxyurea. They're already on a maximum tolerated dose, but they're still not able to control that hemolysis. They still have high hemolysis at steady state. So I believe that these therapies, and of course the gene therapy, they're actually ongoing trials looking at cerebrovascular complications. It takes years to be able to prove this. And this is something we can definitely now approach the companies for, to start conducting studies, to start looking at these new therapies with risk of stroke or developing this silence. In fact, how many of the people on? And I think now is the time to start doing the study. Yeah, on these therapies, because I'm pretty sure they will work because of the mechanism of action. They work better than, the way they work in improving hemolysis is actually much faster for some of them than hydroxyurea. It's more impressive. So patients that cannot tolerate hydroxyurea, once we have this available, they'll be taking this. Because what I'm saying is that some of the hemoglobin, some of the patients, when they start taking that oxyvelotor, will normalize the hemoglobin. I mean, it has kind of exaggerated response that sometimes I reduce the dose to make sure that the volume is not too much for the heart to take. Because if it's an elderly person, 60-year-old, they've dealt with this small volume all their life, and then all of a sudden, the hemoglobin level went to like 2 times their normal level. It can be too much for their heart if they have diastolic heart failure. Yeah. So it's really very impressive kind of response that people are having to the therapy.
Are there other questions people have? It's really an incredible transformation in sickle cell care since many of us were in training and in residency. Okay.
Yeah, thank you, everyone. And thank you for the invitation, Dr. Savitz.
Absolutely.
I appreciate it.
Thank you so much. Thank you for your time.
Bye.
Take care, everyone.
Thank you.
Bye, everyone.